Hello, welcome back to the ASCO Journal of Oncology Practice podcast. This is Dr. Nate Pinnell, medical oncologist at the Cleveland Clinic and consultant editor for the journal. It isn't exactly news if I were to point out that the traditional system of medical reimbursement, which is what we call fee-for-service, creates an incentive for physicians to bill as much as possible to increase their profits. And while most of us wouldn't be surprised to learn that some doctors push the limit of what might be considered appropriate to make a little extra money here and there, we generally assume that they place patient care first and really profit is a secondary objective. It's very rare for us to be able to shine a bright light on true abuse of this system, and that's what today's guest is going to help us learn about, an example of this that he was a part of in the last year. Joining me today is Dr. David Steensma, Associate Professor of Medicine at Harvard Medical School and medical oncologist at the Dana-Farber Cancer Institute. He's going to be talking about his paper, The Farid Fata Medicare Fraud Case and Misplaced Incentives in Oncology Care, scheduled to be published in the JOP later this year. Dr. Steensma, thank you for joining me today.
Thank you for having me.
So, I thought this was a very interesting paper. Can you just briefly tell us a little bit about Dr. Fata's case and how you ended up being involved in it?
So back in 2013, Dr. Fata, who was an oncologist in suburban Detroit, Michigan, was arrested and charged with a number of counts of healthcare fraud, money laundering, and a count of conspiring to pay and receive kickbacks, which in this case was cash payments for referring patients to a particular hospice and home healthcare company. Ultimately, Dr. Fata pled guilty to 16 of the charges, and in July of 2015, he was sentenced to 45 years in prison by a federal judge in Detroit. He is an oncologist, and many of the healthcare fraud charges related to excessive use of diagnostic testing and of certain medications, especially expensive supportive care medications.
And how did you end up involved in this?
Well, so I had no interest really in getting entangled in the legal system. I was approached in 2013 by the U.S. Attorney's Office, and they said they had some case files that they wanted me to review. They said that this was not a civil case, it wasn't a malpractice case, this was a criminal prosecution, and the physician was being charged for over-treating patients, including a lot of patients with blood disorders, with hematologic malignancies. And my initial reaction was one of skepticism, and so I agreed to look at some of the files, thinking that I was going to be looking at some overzealous Medicare auditors' efforts to try to send some busy community oncologists up the river for, coding an E5 E&M code when they only had enough review of systems boxes checked off to justify an E4. And I was not prepared for what I actually did see, which was, in my opinion, really gross overtreatment and mistreatment of patients who didn't have indications for treatment.
I appreciate this is a legal case and there might be some limits to what you can tell us, but can you give us some examples of the abuse that you found in the case files?
So one common pattern was treating patients with monoclonal gammopathy of undetermined significance, MGUS, with bortezomib and dexamethasone, and then a lot of supportive care medications to go along with that. Intravenous antiemetics, including daily use of Aloxi, which is a medication that really shouldn't be given more than about every 3 days. Multiple antiemetics from the same class, giving a patient Aloxi plus Kytril. Lots of hematopoietic growth factors, EPOTN, GM-CSF, G-CSF, vitamin B12 injections, bisphosphonates, intravenous iron salts, intravenous gamma globulin. Intravenous gamma globulin, even if the only thing that was abnormal about the globulin profile was a low IgA, in which IgG that's in IVIG doesn't help with, and in fact, IVIG is contraindicated for IgA deficiency. So, it was that was one example of the types of what I thought was really excessive treatment.
That's incredible. So a lot of this, using growth factors and whatnot, we think about, maybe it's not completely appropriate. Sometimes maybe do that to make a little bit more money, but not necessarily hurting the patient for that, maybe just giving not quite the best of quality care. Were there specific examples that you found where patients were harmed from this overtreatment?
I believe so, and that really is what made it so troubling. I mean, there are lots of situations in which we make judgment calls or in which we need to prescribe something that doesn't quite fit a published guideline because the patient doesn't quite fit the published guideline. That happens all the time in oncology, and often there's disagreement between one physician and another in a gray area about the appropriate treatment for the patient. And that's what's so troubling about our malpractice system, is that it just has many, many flaws in it. But again, this was not a malpractice situation. This was a criminal fraud trial. And so a good example of someone who I thought was harmed was a patient with MDS who progressed to acute leukemia and then was given an intensive induction regimen for leukemia as an outpatient. So that Dr. Fata's practice could bill for the infusion chair and the chemotherapy drugs. And this patient developed tumor lysis and renal failure, was on dialysis, got out of the hospital after having recovered, was given a different intensive regimen, and shortly thereafter died. So that was a particularly troubling example. It's very hard, as you know, Nate, to connect the dots. A happened, there was a result B, and A caused B. That's quite difficult to do with certainty. And so there were certainly other patients where I thought the treatment may have harmed them, but just couldn't be sure about that. But this was one where it was clear, the patient got this intense therapy, which really, if it was to be given at all, should have been given in a carefully monitored inpatient setting. And then the patient had a predictable complication.
Yeah, and it's easy to imagine that this may have just been the tip of the iceberg about potential harms that could have happened. So in your paper, I found it very interesting that you described some of the reactions of the family members of the patients afterwards, and speculated that this type of case, when broadcast in the media, might even influence patients' faith in oncology and in modern medicine in general. Can you tell me a little bit about your thoughts on that?
I avoided looking at any kind of media during the preparation for the case, during the case, but afterwards, certainly once the judgment had been handed down, once my role was completed, I did look at a number of the articles in the Detroit Free Press and in the national media about the case, and the comments were really quite troubling. These were folks who said, medical oncologists are all like this. They just want to give chemotherapy and serve themselves and the pharmaceutical industry and make a lot of money, and chemotherapy doesn't help patients. And if you get diagnosed with cancer, you should go to Mexico or go to a natural products doctor and not to a conventional medical oncologist. And so, there's always trolls and crackpots on the internet, but this was, lots and lots of comments like that. And then I started getting letters from family members of patients after the trials saying, they had been diagnosed with cancer themselves and they couldn't bring themselves to trust a medical oncologist. They had other family members who now they were questioning their care. And so I think it really, among the sad consequences of this case is breeding a distrust among patients and family members of really the great benefits that cancer medicine can bring to people in the 21st century.
Yeah, I know it's hard to tell from internet comments how much that reflects the general public's opinion, because it does seem to attract trolls and such who aren't necessarily even reading the article but want to be able to push their own agenda. But in this case, certainly you can see how this would influence people to be a little more suspicious and a little more probing of their doctors about the appropriateness of what they're doing. Obviously, this is a very extreme case, but you have to wonder if perhaps less egregious examples of this kind of overuse for profit is happening throughout the U.S. What do you think about a current fee-for-service health system and how this feeds into this kind of incentive?
Well, I think fee-for-service is attractive in some ways because it's very easy to track, and it's easy to make the billing and the payments work from a sort of logistical standpoint. But the downside, of course, is that it incentivizes doing things that may not be in the best interest of the patient. And although the Dr. Fata case is particularly exceptional and egregious, and the U.S. attorney said that as far as she could tell, Medicare fraud hasn't happened on a scale like this anywhere before, at least with respect to the number of potential victims. There have been other cases. There was earlier this year a neurosurgeon who pled guilty to performing unnecessary spinal surgeries and billing for durable medical equipment. So I think these sorts of other cases suggest that the Fata case is not an isolated incident, and we really need to think about how we are rewarding or what we are incentivizing with the current payment system. And so I think if there's one sort of take-home message from this just tragic situation, it would be that we really need to rethink about what we're incentivizing, because somewhere there's going to be somebody who's acting on those incentives.
And I know that there's a lot of discussion now about using alternative models for payment beyond fee-for-service. How do you think that would prevent something like this from happening?
Well, I think there would have been no incentive to, for instance, treat a patient with monoclonal gammopathy of undetermined significance, and so they would have just been observed, and that would have been the right thing for the patient. So that's a specific example of how a focus on outcomes would have been something that potentially led to less risk or less harm in this case.
Dr. Steensma, thank you so much for joining me today to talk about your paper.
Thank you for having me.
And I also want to thank the listeners who's joined us today on this podcast. The full text of the paper will be available soon at jop.ascopubs.org under early release. Don't forget that you can read the JOP and access these podcasts on your smartphone or tablet with the ASCO Journals mobile app, available in the iTunes Store and Google Play. This is Dr. Nate Pinnell for the Journal of Oncology Practice signing off. Thank you for listening.